Welcome, everyone. Thank you so much for joining. We have a really exciting topic to discuss today. We will be sharing about motivational interviewing and how these skills can be applied to navigate conversations around vaccine hesitancy and helping build vaccine confidence. I will be the host and one of the presenters today for the session, and then we will hear from our guest speaker, Jonathan Kratz, in a little bit. I'll do a little informal introduction of myself, but my name is Alyssa. I am for Peck, Sioux, Assiniboine. I've been a program manager at NCUIH for over 3 years now. I'm based in Seattle. I know that football season started, so I have my Seahawks earrings on. And I will also be joined by Sophie in the chat. She will be monitoring to see if you have any questions and then also sharing any links that we discussed today. Next slide. So today's session will be recorded for educational and quality improvement purposes. We do ask that you turn on your video if you can, mute yourself when you're not speaking, and then I invite you to introduce yourself in the chat by providing your name, organization, and any tribal affiliations. Next slide. So we have a lot of great material to cover. We'll describe key motivational interviewing techniques. We're going to discuss vaccine context among American Indian Alaska Native communities. And then we'll also see an example of applying motivational interviewing in a conversation about vaccinations. We'll have a survey at the end of the session that we ask you complete if you can. These responses really help us to ensure that we're doing the best job we can. And we'll share a QR code later on in the session so you can access that. Next slide. NCUIH acknowledges that our national office in DC and nearby activities are situated on the traditional homelands of many Native nations. Some of the communities in the surrounding area include the Piscataway, Pamunkey, Nantego, Mattaponi, Chickahominy, Monacan, and Powhatan peoples. These lands have deep historical, cultural, and spiritual significance to Native peoples. Next slide. To provide some background on NCUIH, if you're not familiar, the National Council of Urban Indian Health is a national representative advocating for the 41 urban Indian organizations, or UIOs, contracting with the Indian Health Service under the Indian Healthcare Improvement Act. Next slide. All right, so please help me in welcoming Jonathan Kratz. He is a clinical associate professor at the University of Oklahoma. He teaches across the direct practice curriculum in the Anne and Henry Zarrow School of Social Work, including courses in mental health, advanced clinical social work, and the integrative seminar. He is a primary investigator for the Healthcare Initiatives team at the Suicide Prevention Research Center, and his work at OU focuses on clinical pedagogy related to motivational interviewing, suicide prevention, intervention, postvention, and high-fidelity clinical simulations. He's also a member of the Motivational Interviewing Network of Trainers. So, Jonathan, I will hand it over to you, and we're really looking forward to hearing from you.
Thank you all for having me today. It's nice to be with you. So the agenda is to kind of go over the basics of motivational interviewing. This is a model that is, as you can see, we can kind of cover it in about 30 minutes. But it's also not just sort of a model that you think about and understand sort of like intellectually, but it's a skill set. And so I'd encourage folks who are interested in deepening your knowledge around motivational interviewing to be on the lookout for opportunities to join, especially live workshops in your community. These trainings tend to happen all over the country, and those are a great way to not just hear about the model, but also practice some of these skills in a practical way. My agenda is to go over the fixing reflex, the spirit of motivational interviewing, the core clinical skills we use in this model, which are called OARS Plus, and then we'll also talk about the 4 tasks of motivational interviewing. So those are sort of the big topic areas. I don't have anything to disclose. As Alyssa already kind of introduced me, I'm a faculty at the University of Oklahoma in our School of Social Work. I also do work with our Suicide Prevention Resource Centers, Healthcare Initiatives team, and I've been a motivational interviewing trainer for about 5 years. So to kind of start things off, I wanted to invite you all to be thinking about the ways that we react when we encounter patients who are making choices that are potentially harmful to their health. And what is pretty normal, especially in helping professions in sort of medical settings, is when we notice a potential change in somebody, that our first instinct is just to share that change with them. And I would invite you to think about how it feels to be spoken to this way. For example, if I were to look at someone and just say directly to them, hey, you need to take your medicine every day, or you should cut out sugar and carbs from your diet, or maybe you need to exercise more, you need to get vaccinated, you need to stop eating so much fast food, you need therapy. And I would just like you to notice how it might feel to be spoken to this way, to have somebody to say this type of thing to you. And what we're talking about is what's called the fixing reflex, which is very common and very normal, I would say even sort of natural in sort of helping professions. That people who are counselors, physicians, nurses, healthcare professionals, that we get into this line of work because we want to help people. And so we usually have pretty sensitive fixing reflexes. So when we see a problem, we want to dive in with both feet and do something about it. And sort of the whole point of motivational interviewing is this acknowledgement that there's a sort of core problem with the fixing reflex, and that it often has sort of a counterproductive impact, even counterintuitive impact on the people that we're trying to help. And on the screen here, I have a few examples of ways that the fixing reflex maybe gets us something different than what we intended. Um, the first one is whenever I look somebody in the face and say, hey, you need to lose some weight, part of what I'm communicating to that person in that moment, even though my intent may be pure to help them, but what they may be hearing me say is that somehow I don't think it occurred to them that they need to lose weight, that somehow I'm giving them new information. And one problem with the fixing reflex is just for some patients, it kind of has a function of being an insult. This idea of when we give the information, sort of implied in that process is that the patient didn't know and that I'm giving them something new. And that's maybe not what our intention was, right? We want to help, but maybe we've been going around insulting people. Sort of related to that is the emotions that can sometimes be elicited in an individual whenever we kind of fall into this sort of directive fixing mindset. And one really common emotion is the emotion of shame. Like when I say, hey, you need to improve your diet, might be a kind of directive statement that elicits a shame response in an individual. And something that we have plenty of research on, we have lots of research on lots of these emotions, but shame in particular is not associated with people making positive changes in their life. And so if the way that I am talking to my patient is evoking shame in them, I've actually made them less likely to actually follow through with whatever health change that we're talking about. Another emotion that might emerge from the fixing reflex is something that's a little more harsh, like discord. This idea of who are you to tell me how to live my life? And the sort of reasserting of agency and autonomy is another really common response to fixing efforts. But the most important one, and the one that we'll spend some time on today, is on the bottom left of your screen, which is this idea that when I tell somebody, hey, you should do this behavior change in your life, just conversationally, what I've done when I've made that statement to them is I've opened up a door for many patients to respond with an answer that goes something along the lines of, yeah, but let me explain to you why that's really hard for me. And what we're going to talk about today and what motivational interviewing is all about really is about the power of language, and in particular, who is saying the words. at the end of the day, if you have an aspiration for your patient's health, that's is all it is. It's an aspiration. And that when it comes to behavior change, our patients and clients really have all the power when it comes to making any decision about what they do about their health. And that we can't actually gift motivation to anybody. We have to find ways to evoke it from them. And another way of saying this is that the words your patients say have a ton of power. This idea that when a patient verbalizes arguments in support of change and in support of improving their health, that those arguments they verbalize are associated with an increased probability of them actually being successful making those changes. On the flip side, every time a patient verbalizes arguments for the status quo, it has the inverse impact on them. This idea that the more they verbalize language around not changing, the less likely they are to make a change in their life. And basically, what motivational interviewing is a way of talking to people about change that helps them say the words. It's about evoking instead of fixing. So on the screen here, you can see an example of I could go to a patient and say, hey, you need to take your medicine every day. And who knows how they'll respond to that. Maybe it'll be helpful to them. But can contrast that to me having a very intentional, maybe 5, maybe 10-minute conversation with that same patient, where towards, the later half of that conversation, they say the words, you know what? I need to remember to take my meds every day. It's the same sentiment, but where the words are coming from has a ton of power. Me saying it to my patient, less power. Them verbalizing the change, more power. Another example would be to our point of the topic today. If I go to a patient and say, hey, you need to get vaccinated, as opposed to having a 5 to 10-minute conversation with them where I help them say the words, I want to stay healthy, and I'm starting to wonder if vaccination could be part of that. Same sentiment, but where the words come from have a ton of power. And so that's basically what motivational interviewing is all about. It's a series of concepts and sort of strategies and skills that we use to kind of help a conversation progress where our clients are empowered to say the words. The definition is basically it's a particular way of talking with people about change and growth to strengthen their own motivation and commitment to change. Um, the model has been around for quite a while now. It's one of the most studied modalities in psychotherapy, well over 2,000 controlled trials, hundreds of meta-analyses, and motivational interviewing is probably second only to cognitive behavioral therapy when it comes to just the volume of literature and evidence we have for the model. A little history on the model. It got its start in the 1970s, primarily for folks who have substance misuse problems. And in the decades since it was first published, it has been shown to be an effective modality for all kinds of different practice areas and in sort of topic areas around change. And in fact, so much so that researchers in this space actually find it a little bit uncomfortable because, anytime a person like me comes to a group of people like you and shows any slide that looks anything like this one, you should become immediately suspicious of that person because it does seem too good to be true. And that sort of bothered us, like this question of why is this so effective in so many just varying contexts? And really what the research has been telling us is that it actually has very little to do with any of these words on the screen here. That the reason motivational interviewing is helpful in so many different practice areas is because it can be helpful in situations where a person is ambivalent about a behavior change in their life. So if you have those two pieces, a person who's ambivalent about a behavior change, then you have potentially a situation where motivational interviewing might be helpful to that person. So as we think about ambivalence, it's helpful maybe to think about the trans-theoretical stages of change, which is a model that we've used for decades to talk about the relationship a person has to a change in their life. And this is a nice way of also conceptualizing where motivational interviewing makes sense. We have pre-contemplation where someone's not even thinking about the change, contemplation and preparation, where there is some cognitive energy behind it, maybe a little bit of behavior preparing to do the change. Obviously, action is when someone's starting to carry out the change, and then maintenance where they're trying to maintain it. And the reality is motivational interviewing has value and something to offer at all five of these different stages, but we'll primarily be focusing on the first three, pre-contemplation, contemplation, and preparation, as sort of a space where a lot of these techniques really make a ton of sense. So if what we're talking about is helping people who are ambivalent about a difficult change, maybe a helpful thing for us to do next would be to talk about why exactly is it that people have ambivalence around especially health-related changes in their life. Why do people do things that appear to be against their best interest? And this is something that in motivational interviewing, we talk about using the concepts of change talk and sustain talk. It's meant to be, to use my metaphor on the screen here, two sides of the same coin. That when somebody is deeply ambivalent about doing something, all it means is that they have, on one hand, some reasons why they would like to make that change. And on the other hand, maybe a list of reasons why it's hard for them, or maybe why they don't want to make that change. And that when somebody is deeply ambivalent about something, this is basically all that's happening. It's just that they have some combination of change talk and sustain talk going on in their life. And let me tell you, if somebody's having a conversation with you about, something like vaccination or any other health condition, by definition, they are at least on some level ambivalent about it. Otherwise, you all wouldn't be talking about it. And so ambivalence is a normal thing to encounter in medicine, and it's just part of the human condition. This is my favorite picture about ambivalence. It's so normal, right? And I love this image here of an escalator into a gym. This idea that somebody is, they just need that extra little push to make the decision to go exercise. And I'd like to imagine that one of these guys is about to go get on a stair machine or something, just to drive home the point. But the idea is that being ambivalent is part of the human condition. It's actually a very normal thing. But when somebody is deeply ambivalent and deeply conflicted about a change in their life, there's also some problems that can kind of creep into that dynamic. First of all, the status quo has a huge advantage. If someone is deeply ambivalent about changing something in their life, it's a pretty good chance they're not going to do it. The story I always tell is I have been somewhat ambivalent about going to the gym 2 or 3 days a week for about 20 years. And it's something I've been personally working on for decades now. And this idea that if you're ambivalent about doing something like that, it takes a lot of energy to do it. In 20 years, I've never accidentally gotten up at 5 a.m. to go to my gym. It's something that takes a significant amount of effort and dedication for me to make that happen. And that's the problem with ambivalence, is that staying the same has sort of a home court advantage, or to lean into the image on the screen, it's a really unfair playing field. This idea that the team trying to score downhill is sustain, the team trying to score uphill is change. And the default decision for a lot of our patients is to not change. Adding on top of that, you already have that sort of unfair playing field. Then we have healthcare professionals being directive with an individual, where you may have the blowback effect, where someone then kind of digs their heels in around the topic, or what we were talking about with motivational interviewing, where somebody has sort of a paradoxical impact of coercion, where we're just helping deepen their sustained talk. And so basically, motivational interviewing says that if we increase change talk and decrease sustained talk, that has a relationship to somebody making a change in their life. And so the more I can help my patient verbalize change talk language, that has a relationship to them actually making that change. And the more I can sort of take the power away from their sustained talk, it has the same outcome, that has an association with increased change. And so just real quick with my last 15 minutes here, let's go through what this model is all about. So how do I have a 5 to 10 minute conversation with somebody where we have them verbalize some change talk and actually say these words? And the frameworks we look at are the spirit of motivational interviewing, OARS Plus, which is the core clinical skills, and then the 4 tasks. So the spirit of motivational interviewing, I'm not going to spend a ton of time on this one. It's something that maybe takes a little more energy to kind of go over fully and do its full justice, but it's basically the relational traits you bring to an encounter with a patient. And what motivational interviewing encourages that you have a spirit of partnership, acceptance, empowerment, and compassion with your patients. And these traits are associated with certain expressions of those traits, sort of behavioral skills that kind of go hand in hand with those internal traits. And it's important to think about how we present these. So partnership is all about acknowledging that the client has all the power, and that to have a spirit of partnership is to recognize that reality. And so it's not about giving up authority and coming down to a patient's level. It's acknowledging that the patient has all the power, and that if I want a chance of being able to help them, that I'm asking them to share some of their power with me. That's the spirit of partnership. The spirit of acceptance is that I'm asking them to share their power with me, and I'm going to accept what they decide to do with that power. Acceptance is really powerful. In the research, clients never talk about acceptance using that word. They always use the word respect, which is so interesting to me. This idea that when I have an accepting spirit to a patient, the way they interpret that is this person respects me, and how powerful that can be in the relationship. Empowerment is what we're talking about. It's basically helping the words and the motivation come from the client. And then compassion is finding ways to convey to them that we have some skin in the game, that they matter to us, and that their health outcomes are also important to us as helpers. Whether or not you have the spirit of motivation of motivational interviewing or not, relational skills happen regardless. That's part of the nature of human services. And I always like to think about the alternative, that if I'm not giving partnership, acceptance, empowerment, and compassion, it's probably some combination of these things that's happening in that relationship. And that can be something that really diminishes our ability to be effective with our patients. All right, so the core clinical skills are open questions, which is basically any question you ask that invites the patient to do more talking. And so an open question is a question that they can't answer with a yes or no. And so finding ways to have open questions is part of that evocation. We want the patient to say the words. Affirmations are a form of reflection where you highlight a strength in your patient, so some sort of positive trait or value you see in them. And that's something that we also encourage a lot. Reflections, again, affirmations are a type of reflection, but then we also have just general reflective statements, which we'll get into in more detail here in a minute. Summaries are basically longer reflective statements and are also pretty valuable. I did want to take a minute here and talk about giving information because it really matters a lot in health contexts, which is basically an answer to the question, like, what do I do when I think my patient needs a lecture from me? And the model we teach for giving information is called ask, tell, ask. So step one is make sure the information is missing. So if I ask a patient, what do you already know about how this medication works? And their answer conveys basically what I was going to tell them. What the patients just told me is that the information is not missing. They don't need a lecture. And so we just move on. But if their response indicates there's some missing information, then I ask for permission to share some of my knowledge with them. Would it be all right if I shared a bit about the research on this medication with you, or what I've learned from working with other patients? You give the information, ideally with a stance of neutrality, and then evoke on the back end. How does that fit with your experiences so far? And so this is a nice little way of thinking about what it means to give information to patients without barking orders at them and getting directive right out of the gate. All right, so those are the spirit of motivational interviewing, the core clinical skills, and they are used in really intentional ways across 4 basic tasks of the model. And it starts with engagement, then to focusing, evoking, and planning. And they're meant to be sequential, like a staircase. You start at the bottom step and you climb along with your patient. I would suggest that a lot of frustrating situations in healthcare settings involve basically the healthcare provider standing on the planning step, yelling down to the bottom of the stairs at the patient who hasn't even agreed to connect with them yet. And that walking with your patient is part of how we lean into this metaphor. Kind of not to mix my metaphors, but I really like an example that Bill Miller, the creator of the model, uses where he says that our work with patients is like going on a walk. And that when I'm engaging with my patient, it's like I'm asking the question, may I walk with you? When I'm focusing with my patient, I'm asking the question, where are we going? When I'm evoking with my patient, I'm asking the question, why would we go there? And then when we're planning, we finally get to the question, how are we going to get there? And that when you do those processes in order and think of it as a walk, it really helps kind of deepen the sense of why these different tasks matter. So let's start at the bottom of the stairs. Engagement's pretty straightforward. It's, may I walk with you? At this point, the skills we use are non-directive reflections. and open questions. Basically, it's this idea of I'm trying to gain a connection to my patient, understand their perspectives. Um, uh, the big skill here and throughout the model is reflective listening. And what reflective listening does is it basically helps complete this broken feedback loop that we see in a lot of conversations where our patients have their internal subjective experiences. They use this crude instrument called words to try to convey them to us. We have to hear those words, then reinterpret them. And what a reflection does is it completes this loop. It says, this is what I heard you say, or this is what I think you mean. And when we offer that to a patient, even if we're off the mark, it still is deepening our relationship with them because it conveys this is a person who's trying to understand me. And that's why reflective listening matters so much. There are simple reflections, which are basically obvious things that we've heard from a patient. And then complex reflections tend to try to get below the waterline, to use my metaphor here, to capture more of the meaning behind what they're dealing with. And so if we looked at an example where we have a patient who says, I've been depressed lately. I keep trying things other than drinking to help myself feel better, but nothing seems to work except having a couple of drinks. I could reflect what they've just said using a simple reflection like, you've been feeling down, and the only thing that helps is drinking. It's basically capturing the core of what they said and repeating it back to them. Or I could do something that's a little bit deeper or more complex, like a double-sided reflection where drinking helps in the short term, and part of you recognizes this may not be a great long-term strategy. Or a feeling reflection, you're frustrated by the lack of payoff on your hard work. A metaphor, it's like you're covering a wound with a Band-Aid, and although it temporarily gives the appearance of healing, the wound is becoming infected, and it needs more effective treatment than a Band-Aid can provide. Or maybe an affirmation, you're determined to find healthier ways to cope. And so the idea is that basically reflections have certain functions because they also, in addition to connecting around meaning with a patient, they also have certain sort of meta communication going on. This idea that when I do a simple reflection, what I'm telling my patient is, I hear what you're saying. When I offer a more complex reflection, I'm saying, I understand what you mean. An affirmation, I see your strengths. A feeling reflection, I understand your emotions. Or a double-sided reflection, I hear your ambivalence. And the research is clear on all of this stuff. Reflective listening really builds empathy with patients, and just meta-analysis after meta-analysis shows positive outcomes for patients when they have providers who are high in empathy, and reflection is how we show that. All right, focusing is, again, we're moving on. Engagement, may I walk with you? Focusing, where are we going? And in healthcare settings, what I found is that oftentimes, you have the 15-minute session, especially if you're a physician or a nurse, where you have to visit with the patient, make some decisions, and kind of have a conversation about their health. And something that really can help a lot in that process is what we call agenda mapping, which is helping a patient to sort through all the stuff that's going on and make a decision about what matters most to them in that moment. So my example here is a patient that says, I'm so overwhelmed, my blood pressure is too high, and I probably need to start on some medication. At the same time, my sugar levels keep creeping up, and I've been told I should be more careful about what I eat and also get some more exercise. I know I should also quit smoking, but that feels really impossible right now. And it just feels like there's so much wrong with me all at once that I don't even know where to start. And so what we could see is in this patient, they've identified a few topic areas: medication, diet and exercise, smoking. And we could use a summary statement to try to help them make a decision. So you reflect what you're hearing and then ask them and give them some empowerment around what we're going to focus on today. So here's an example of, many people feel overwhelmed when there are several health issues that come up together. And sometimes it helps to pick one place to start. So instead of trying to tackle everything at once, we could spend our time talking more about medication or diet and activity or smoking. I'm wondering what feels most important to you right now, as a way of using a summary statement to reflect that we've heard everything and then help them make a decision. Now, evocation is where the model really catches on to what we were saying a minute ago about getting or helping our patient to say the words. So why might we go there, helping them to verbalize it? We don't really have time to go into the weeds around the different types of change talk, but the idea is that not all change talk is the same. There's this acronym DARN is what we use to sort of capture the different types of change talk we might hear from a patient. But evocation is relatively, if you distill it to its essence, a pretty simple process. It's when you hear change talk, you reflect it. When it's missing, you ask for it. And so it's a pretty simple sort of cadence in that 5 to 10 minute conversation. The idea is you want to, again, try to level that playing field. Sustained talk doesn't need your help. So typically we just ask for change talk. So instead of asking for a question like, why haven't you changed, which is going to get you some sustained talk, we'll ask, what are some of the benefits of making this change that gets us more change talk? Similarly, with reflections, we try to give preference to reflecting change talk, especially on that third evocation step. So if a patient says, I really don't want to stop smoking, but I know I should, I've tried before and it's really hard, there's a bunch of different reflections I could offer that are all pretty accurate. But only one of these is adherent to motivational interviewing, because it's that third one on the bottom that actually captures the change talk in that person's statement. It's pretty clear to you that you ought to quit. Another example would be if a patient says, my blood sugar runs high, but most people eat the same way I do. It's not like I'm eating junk all the time. It's irritating that this cut on my leg is taking so long to heal, but outside of that, I don't think it's as serious as people make it out to be. So if I were to code this patient's language, the green letters would be the change talk I'm hearing, and then the red letters, some of the sustained talk. And I can offer a nice double-sided reflection to capture and deepen some of their change talk. The way you've been eating feels normal to you, and it would be really upsetting if this wound that has been so slow to heal became infected or worse. Um, Here's another one. People always say that you're not supposed to drink during pregnancy, but I've been so stressed, and a small glass of wine in the evening is all that really helps me relax. One of my friends made a comment about it, and that was a little embarrassing. So I mostly just drink at home now. I know people who drank a little during their pregnancies and their babies were fine. And so here again, if I were to code this, there's change talk. Even in somebody's statement that might feel pretty resistant at first, you can find that change talk and reflect it. It was embarrassing when your friend called you out. And even though you've known other women who used alcohol during pregnancy, part of you worries that maybe they were just lucky, and it would be really upsetting if alcohol caused problems for your baby. And so that's how we build evocation in a healthcare setting. Usually you're talking, again, like 4 or 5 minutes of evoking, asking for change talk, reflecting it when you hear it. And then finally, if it gets to a point where you feel like you've heard a lot of change talk from your patient, you might check into about making a plan to see if they're interested in actually making that change. How will we get there? Um, I like to think of planning as sort of what we're doing all along in many ways, because really the whole motivational interviewing process is about building hope in a patient or a client. This idea that hope is identifying a clear goal and having the willpower, the motivation to pursue that goal, but then also the pathways or way power to get from here to there. And, when we are doing motivational interviewing, we are basically having a conversation that builds each element of hope. We're identifying the focus area. This is the change target we're working on. I've helped my client to verbalize their desire, reasons, and need to make that change. And ideally, also, we've, started thinking about how are we going to do this? What are my abilities around making this change? How committed I am to it? And when you put all of those pieces together, essentially, you have somebody who leaves, again, a 10 to 15-minute session with a healthcare provider being a little more likely to make a change. But even if they don't make the change, this type of conversation with patients tends to pay off in the long run. This idea that when I come back to my physician next time, or I talk to the nurse next time, they were helpful to me last time, and that they made me feel a little more hopeful. And sometimes change is a long game, right? This idea that it can take, a few sessions or a few months for somebody to finally get to the point where they're ready to make the change happen. And so here's my references from some of the citations throughout that. And that's basically my motivational interviewing 101. And I think I have exhausted my 30 minutes, and I will hand it over to Alyssa.
Wow, John, that was wonderful. I could have listened to you for the whole presentation. You said something that really stuck with me. It was, we cannot give motivation to a client, but we can evoke it. And I really connect to that. And I feel like in a healthcare setting, people are already coming there for a reason. I mean, they care about their health, they want to be treated. And so I really like that quote. So we do have a moment if there are any questions to take maybe one or two, and then there'll be another opportunity at the end of the session to ask more questions. So I'll see if anybody has anything. You can put it in the chat, come off mute. All right, no worries. If you think of something, just put it in the chat as we go, and we'll take a look at it towards the end of the session. All right, next slide. So I'm gonna kind of switch everyone's brain now a little bit and start talking more about vaccines. I know a lot has been changing right now around the COVID-19 vaccine in the past month, and so I did want to share just a few updates to keep everybody updated. Next slide. So this is a little less recent, but you probably heard back in May that the Health and Human Services Secretary Robert F. Kennedy Jr. had announced that the CDC would no longer be recommending the COVID-19 vaccine for healthy children and healthy pregnant women. The CDC did respond to this by updating their vaccination schedule. And then more recently in August, we saw on social media that RFK Jr. had shared that the updated COVID-19 vaccines were recently approved. Within that approval, there was a narrowing in the indications. So they're only indicated for adults 65 and older, and then for children and adults with high-risk conditions. There's a lot of confusion kind of going around about this right now of like what are high-risk conditions. The CDC does have a list that you could refer to, and then right now it seems like kind of moving towards that shared decision making. The CDC hasn't updated on their website yet the 2025-2026 approved COVID vaccines and their indications, but that's something that I assume will come in the coming months. Next slide. And then just kind of something to bring to your radar, but the CDC's Advisory Committee on Immunization Practices, ACIP, so they haven't voted yet on COVID-19 vaccine guidance, but they are actually meeting for I think it's a quarterly convening that they do. So they'll be meeting on Thursday and Friday. This is something that you're able to stream live on YouTube, so you can watch the entire conversation take place. And then it looks like the agenda, at least the draft agenda, is showing that on Friday, they have pretty much the whole day set aside to talk about the COVID-19 vaccine, and then towards the end, they are supposed to vote on it. So hopefully in these coming months, we'll start to get some clarity, especially as we're entering into the respiratory season. Next slide. So I know it can be hard to stay up to date, even myself, it's a lot to try and find information. Things can be conflicting. And so we recently launched our Native Health Protection Network. And so by joining this, it's basically an email network. And so you'll receive emails from us that provide updates around all vaccination landscape, resources, tools, trainings, things like that. So you can join by scanning the QR code, and then you can also visit the link in the chat and just provide your email. Don't worry, we won't spam you or anything, but just, prudent updates and maybe like a quarterly email. Next slide. All right, so now John did a great job at talking about motivational interviewing in the context of vaccination as well, but we'll kind of dive a little bit deeper into that. Next slide. I did want to start us off by highlighting this excerpt from this. This is an incredible manual that is accessible online. It's called Native American Motivational Interviewing, Weaving Native American and Western Practices. And so one of the things they start off with in this manual is describing motivational interviewing in ways that can connect potentially to different communities or Native communities. And one of the things that really connected to me was the using of prayer to describe motivational interviewing. You could consider this a prayer, you could consider it, more just like a story. But I will read it really quickly, and you'll probably notice pieces that may connect to you from what John just shared. Guide me to be a patient companion, to listen with a heart as open as the sky. Grant me vision to see through her, his, their eyes, and eager ears to hear his story. Create a safe and open meadow in which we may walk together. Make me a clear pool in which he may reflect. Guide me to find in him your beauty and wisdom, knowing your desire for him to be in harmony, healthy, loving, and strong. Let me honor and respect his choosing of his own path and bless him to walk it freely. May I know once again that although he and I are different, yet there is a peaceful place where we are one. Next slide. All right, so just a few minutes on the vaccine context in Native communities. It's important to understand some of those historical context behind vaccine hesitancy or low vaccine confidence in Native communities. This isn't an exhaustive list, but some of the ones that I felt were important to share. So there's historical trauma, discrimination, healthcare system distrust in Western medicine, lower levels of satisfaction with healthcare, distrust in research, that deficit narrative, something we see a lot, especially in research that's done not by Native communities, but on Native people, is you'll hear that deficit narrative. And then the ongoing issue of being the racial misclassification, so being misclassified in the data. And there's this little quote on the side that it was, I believe this journal, the National, oh, it's cutting off for me, but they had pulled this from those clinical trials, I think, that were going on the Navajo Nation, and this was a comment on Facebook about it, but we are not guinea pigs. Next slide. So despite that, there are immense strengths in the Native community around vaccination. They had some of the greatest success when the COVID-19 pandemic was happening and the vaccinations were rolling out. And some of those, again, not an exhaustive list, but can be attributed to that community strength and really that deep connection to our community, trusted community messaging and providers, so culturally responsive messaging. And that really goes hand in hand with that next bullet point of respect for tribal sovereignty. So when the tribes and communities have that decision-making over how their public health initiatives are going and the messages that they're sharing, there's that trusted perception that will come from the community. And then just being rooted in that value system of protecting our elders and our relatives. Next slide. All right, so now we're going to look at an example of a conversation and just some key points to consider when you're having vaccine conversations with your patients. Next slide. So some kind of key points, and John talked a lot about these already, but things to consider when you're having those conversations is engaging the patient respectfully and really promoting collaboration, using empathy and considering vaccine burnout. That's a really big point and something that I have been seeing a lot, and not only among patients, but even healthcare workers just feeling burned out from all the different vaccines that they're constantly being told that they have to do. Like John said, nobody wants to be told, like, you need to go to the gym. And so that's definitely something that you need to remember. And then utilizing the OR skills. So that's the open-ended questions, affirmation, reflective listening, summarizing, simple, strong, and personalized recommendations. You have 15 minutes, sometimes can be really short time that you're having these conversations with people, and so making sure that they're clear and make sense, and then providing the science and stories behind during the conversation. And for me, there's evidence-based practice, but there's also the knowledge that as community members we have, and so I include that when I say science as well. Next slide. All right, so here's the next few slides. We're just going to kind of go over some steps and look at an example of a conversation and how it could potentially play out. A little, it's a little robotic, so obviously this wouldn't be exactly what you would say, but to provide some context. So you have a 40-year-old relative with a history of asthma who presents to her local UIO for her annual exam. And so to start with the conversation, we're going to want to try and engage and build that rapport. So using those open-ended questions. And so you have the provider on the right and the patient on the left. The provider says, "Great to see you again. What's new since the last time I saw you?" And so it's clear that this provider already, has some sort of relationship with this patient, but still, wanting to build and grow on that. And the patient says, "I've been doing good. The kids are excited to be back in school." And so the provider says, "That's great. Back to school season can be exciting. Everyone's happy when the kids go back to school and you don't have them home all day. What are your current priorities for today's appointment?" And so really with that last question there, you're asking that open-ended question. So it's really engaging the client or patient to answer not just a yes or a no. It's also kind of putting that power, like John talked about, in the patient's hands. They're the ones who kind of have that autonomy to decide how this appointment is going to go. And then also just really promoting that collaboration. It's not, okay, so you're here, you need this, this, this. It's more so like, what are you hoping to accomplish today? Next slide. All right, so now that kind of talked, I don't show all the little pieces, for time, but now that they've talked about what the priorities are, you're going to guide and open a discussion on vaccination. So really here focusing on inviting the patient to share and then use those reflective listening skills. And so here, the provider says, you're eligible for your annual COVID-19 vaccine. Tell me your past experiences with the COVID-19 vaccine. So again, it's not the provider saying you need to get the vaccination. It's like, oh, okay, well, you're eligible. Like, what are your past experiences? Maybe they already know since they know this client, but again, giving them that power to share their story of, what is their perception. And so here, the patient says, I received it in the past, but I don't want that vaccine anymore. I don't trust it. Provider says, I understand that you have some concerns about trusting the COVID-19 vaccine. Could you tell me more about them? So here, acknowledging that there's concerns there, and then trying to dig a little bit deeper, like what are these concerns, to understand that really. And the patient says, well, the information is always changing. It doesn't even work. My sister catches COVID every year and she gets the vaccine. So now we have a little more of an idea of kind of like what this person's experience is with it. Next slide. All right, and so in this third step, John talked about this as well, but kind of that sharing of information, so asking permission to share. So this is just a repeat to kind of remind you. So she has said, she doesn't think it works. The provider responds saying, I hear that you're concerned with the frequent changes to the vaccine recommendations, along with feeling it doesn't provide protection. I understand it can be frustrating when information changes frequently. So here, kind of summarizing what she said, and, acknowledging and validating that these concerns are real and this provider feels the same way about it. And then having a pause here, to show that there's that listening going on, and then asking permission to share. Would it be okay if I provided some information about the COVID-19 vaccine based on what you just shared? This response is a response my aunt would say to the doctor. Says, sure, but don't think you can slip a fast one on me, doc. So it's clear they have, kind of a relationship already. Next slide. And so to really wrap it up, that summarizing and planning. So now is an opportunity where you can assess the patient's confidence and see what the next steps will be in this appointment. And so here, I didn't show it, but imagine that the provider shared all this information about the vaccine, and the client responds saying, that's interesting. I guess I can see why it could be beneficial for me with my asthma. And that's kind of that change talk that John talked about, where you can see, okay, well, they're understanding that. And so the provider, not being too pushy, just says, so what would you like to do about the vaccination at today's appointment? And the client says, I'm still not sure about it today, but I will think about it. And that's their kind of that provider opportunity to like, okay, you accept, what they said, and they don't want to do it today. And that's totally fine. And giving that affirmation, I understand and know that your health is important to you. We can see that by the fact that she's even considering changing her mind. And then leaving the door open. We can revisit the vaccine at another time once you've had time to think about it. So, not closing the opportunity. You've planted the seed, and maybe she'll be back the next day. Maybe she'll go to her pharmacy or something like that. But this is just kind of an example of how you can apply those skills in a conversation about vaccination. Next slide. So we do have a couple resources available on our website around motivational interviewing. The one on the left here has a bit more detail about the different OR skills, and I love the plus that John had mentioned. And it also has some prompts, for example, like what do you already know about the vaccine? Oh, your health is very important to you. So this one can be used if you have more time to kind of look through. And then the one on the right highlights those OR skills that we've mentioned. So if you're just trying to remember in a quick moment, can think the open-ended questions, affirmations, reflective listening, and summaries. And I really connect to this version of it in kind of that flow of the medicine wheel, because it's not linear and it's not a step of like this, then this. They really happen in synergy, and it happens throughout the entire conversation. Next slide. If you have a moment and you want something to listen to at work, we do have a podcast that we recently released where we talk a bit about COVID-19 diagnosis and management practices. Seems like 20 minutes, so something you want to do while you're working in the background, go ahead and give a listen. And I think Sophie will be sharing those links in the chat for you. Next slide. All right, we do have again a few moments to open the floor and see if there's any questions that came. And again, no worries. We will be sharing all this information and the materials after the session is over, so you'll have access to the slides. So I'll just give a few seconds of silence and see if anybody wants to come off mute. All right. We can go ahead and, oh, actually, I did have one quick question, John, and I think you kind of clarified it, but that change talk versus sustain talk, because when I first heard that, I thought, oh, okay, well, sustain talk would be the better one because you're trying to like sustain a change. But I think now from what I've understood after you showed examples, the sustain would be like if you have a behavior, for example, like I also don't accidentally wake up and go to the gym at 5 a.m., but kind of continuing to sustain that pattern of not changing. And then the change talk is when you would want to make the change.
Yeah. So basically sustain is sustaining the way things are.
Okay.
And change is, the hard work of doing something different.
Okay. Well, that makes sense. Thank you so much. All right, well, we can go to the next slide and we'll just share kind of a few reminders. And so if something does come up later and you want to ask some questions or receive technical assistance, if you are a UIO, you can request one-on-one technical assistance from us. You can also just email me. My email is here on the slide. Again, like I said, we'll share these so you'll have access to this information as well. But definitely, if you're a UIO and you would like further guidance on things, feel free to reach out. Slide. Sign up for our newsletter. Lots of good information that we share through that. And so we'll put that link in the chat as well. Next slide. We do have some upcoming events. So take a look, a lot of good stuff. Our UIO focus groups to set policy priorities will be taking place on October 7th. We have a session using creative arts expression to explore and treat trauma. There'll be an in-person event in DC, and then our annual conference dates are set. So be sure to book your calendars and hold that spot. Next slide. All right, well, thank you so much again, everyone, for joining. And thank you, John. That was I feel very motivated after your presentation. So I really appreciate your time. Please, everyone, if you can either scan the QR code and do the survey or click the link in the chat, it really helps us so we know how to improve our events, but also what we did well so we can keep doing it.